Hi all, thanks for joining us today. My name is Kevin Coonan. I'm a principal with Baker Tilly. I've been with the firm for almost 20 years, based out of Chicago. And today we're going to talk a bit about effective strategies for health plan network management. So why listen to us? We've got plenty of experience with payers, providers, cross, and other healthcare stakeholders. Myself personally, I've worked with many large multi-state Blues plans, national payers, regional payers, in network management, including reimbursement, network build, as well as value-based care programs, including capitation, ACO programs, et cetera, and have had hands-on experience working with some of the recent regulations like No Surprises Act and transparency. On the provider side, I've helped with benchmarking and managed care contracting. Garrett, would you like to introduce yourself?
Thanks, Kevin. Good afternoon, everybody, and thanks again for joining the call today. My name is Garrett Gosh. I'm a partner with the firm. I'm out of our Milwaukee, Wisconsin office. I sit within our risk advisory practice. So anytime the topic of risk comes up, usually I'm involved. I specialize specifically in the insurance industry, so health as well as P&C. But I think as it relates to, this conversation today, a big piece of what I support is our internal audit practice, outsourced, co-sourced, risk assessing, et cetera. And that will be a part of our topic of conversation today is how do we ultimately combine at Baker Tilly what we do as an internal audit practice with what Kevin and Heather do on the consultative side. So looking forward to today's conversation. And without further ado, Heather, go ahead and take it away.
Thanks, Garrett. My name is Heather Herc. I'm a director in our healthcare consulting practice. I've been with the firm since 2011. The vast majority of my time with Baker Tilly has been spent working with health plans and providers on enterprise technology transformation projects, including things like 21st Century Cures interoperability rules, as well as value-based care contract administration and analytics. So excited to have this conversation with you all today. Thanks for joining.
So at Baker Tilly, we've got a large number of service offerings, specialized solutions for health plans, and these impact obviously other healthcare stakeholders as well. And what you're going to hear about today, healthcare payers and providers, of course, have huge data responsibilities. There's financial processing, integration needs, significant amount of data coming in and out, business logic that's processing what happens with members, with providers, et cetera. So huge data companies and transaction process companies. Heather and I are working on the consulting side have, we regularly design, build, implement, optimize many of these systems, including a lot of the bullets that you see on the left. And then Garrett, maybe talk a little about some of the items on the right-hand side of the call out.
Yeah, so as I teased in my introduction, the right-hand side is more that risk-focused stuff. So whether it's high trust, SOC reporting, internal audit, obviously we have a whole slew of other services as well, but that's really where we start to find some of the intersections between what Kevin and Heather do and what I do. And I think, broadly speaking, the conversation today is how does Baker Tilly come together to provide integrated services to companies and organizations like yourselves in the area of, network management. So looking forward to it.
So on objectives for today, I think one of the key themes that you'll get out of today's webinar is that the key themes is that the amount of complexity for payers and providers, but it has increased significantly over the past 10 to 15 years. Just an incredible expansion in the number of provider networks, the number of innovative payment models, the regulation that governs payers. And so that leads to need for payers and providers to be able to accommodate all that changing environment, and that creates risks. So we're going to talk a little today about what does that mean for regulatory risk, meaning fines or inability to participate in certain types of programs unless you comply. Financial risk. We've got payments. The 20% of the US GDP is healthcare. There's an enormous amount of financial transactions going regularly between payers and providers. How do you make sure that that's correct? Overpayments, underpayments, accuracy. And then we've got reputational risk. Patients have choices, members have choices. So making sure that your organization is serving members well, and it has a good reputation in its communities in which it serves is very important. So we're going to talk about some strategies to avoid some of those pitfalls in terms of network management. Next slide, please. So let's talk about some of the complexity. So new network arrangement types. So 20 years ago when I started working with payers, most payers had a PPO, many payers, even large health plans had a PPO, a broad PPO, and an HMO. There was not retail products. There was not narrow networks, high-performing networks, government networks. And all of those have come about in the past 15 years. And even now, there's a proliferation of the number and types of networks that exist. And all of those networks require build, maintenance, the data that serve them, et cetera, as well. And Heather's going to talk about this in more detail. Value-based care 10 years ago is really starting to emerge. Right? It's existed for much longer than that, but it really started to emerge at that point. And we're going to talk about plans that are grappling with sometimes dozens of value-based care programs in a single organization. And then we've got some regulatory, consumer-focused regulatory impacts as well. So we've got No Surprises Act, transparency and coverage, interoperability. We'll talk a little more about that. And of course, government business has been the subject of a lot of news lately, and how health plans can be profitable or sometimes not profitable, managing the Medicare Advantage programs and Medicaid programs. So Garrett, take us into the first polling question.
Right, first polling question for everybody. And if you were listening at the beginning, go ahead and fill it out as it pops up on your screen. I will read the question for you all, and then we'll maybe give a slight tease on some of the results. How many value-based care programs does your organization participate in currently? A, 1 through 5, B, 6 through 10, C, 10 plus, D, not sure, hard to keep count, or E, 0, or not applicable. So we'll keep that polling question open, but go ahead and click that submit button on your responses. So, right, Kevin did a great job leading in on the complexities, the risks, etc., which we will continue to dive into. But I think we wanted to take a minute and say, what and why is the internal audit person on the phone call today? That we don't see that very often. Why are they here? What's the whole purpose? What's the spin that Baker Tilly is going to put on this? And I think what I really wanted to start out foundationally with is, what is internal audit? I'm not going to read the definition for you, but I am going to highlight the couple terms. A lot of people view internal audit as, hey, they're the auditors who are going to come in after something is already done or built, and then give us a bunch of recommendations and tell us how we need to do things differently or better or sometimes worse. Who knows? I think what I'm going to try and hit here is that internal audit can be consultative in nature. And in the definition, you can see the term consulting and value add and improve organizational operations or processes. So I think the whole point in what we're trying to say here is everything that's happening in the network management space is really, really complicated. It's really, really critical to your all's business. And a lot of times, if you think about it at an ERM level, you'll see, operational risk or compliance risk, what is all in those buckets? And right, internal audit's job is to figure out what's in those buckets and help quantify some of what's in those buckets and then determine what is the residual risk that's left after what management has done to mitigate those risks. So again, I think the key point here is to say you can engage internal audit throughout the process or the life cycle. So if you are just standing up a new value-based care program, and if your internal audit team is well versed in that space, there is absolutely value that they should be able to and are probably more than willing to add as you build that program out. So bring them along for the ride and engage them in that conversation, because that's what they're ultimately there to do. They're not just the people auditing the program after it's been set up. So I put 3 bullet points at the bottom that I really wanted to drive home, in addition to kind of my overarching opener, to say internal audit can consult, not just audit. But a couple other key pieces to it too, right? And you all know it as you're facing it every day, is that, right, you live in a highly regulated industry. And frankly, it's been very scrutinized. And I don't think that's going to go away anytime soon. I think, dare I talk about, the cyber events that continue to happen, there is absolutely a target on, all of your organization's back because of what Kevin just said. It's a big piece of GDPR. There's a lot of money flowing. There's a lot of data, a lot of transactions, and it's sensitive and rich data as well. And I think with that, the risks that you're ultimately facing are more interconnected. So the risk that happens on this side of the organization, how do we know what it impacts on this side of the organization? And is the right hand talking with the left hand, and how are they connected? And right at the end of the day, we're seeing time and time again that what happens over here has impacts over here as well. So making those connections, again, is something that internal audit is really good at, because they sit across the entire organization and can help draw those interconnections and points of connectivity. I think the last comment in where we're going to talk more about it is Kevin highlighted, right? Things have shifted really fast in this space in a very short period of time, likely to continue to change. Some of our perspective is that the network management function is going to continue to be a critical function within your all organizations. So how do we spend the time now in the short term to continue to build out and mature the processes, the models, the risk assessment procedures in that space, so that you're set up for long-term success? So I think, said differently, the hockey puck is headed that direction. So how do we get enough horsepower to support that, both in the short term and in the long term? So what I wanted to tease quickly next, and we don't have to go into great detail on it, but many of you have heard of the 3 lines of defense. And why am I bringing this up now in the vein of internal audit, right? I kind of teased ERM before, which you'll see as that second most pillar to the left. You see internal audit in there, right? Ultimately auditing against, the organizational's risk tolerance and ERM program. And then the risk management, much of the risk management that happens within organizations is within that first line of defense, right? That operational component that is ultimately driving the business, then management that's overseeing those operations. So I think the point here is that, right, internal audit, while we can sit as that third, sometimes fourth line of defense, sometimes second line of defense, depending upon your organization, how can we engage them early on to be in there with the operations team members, consulting on what can be done proactively, foundationally, to build out a strong program that then meets the organizational risk tolerances. And then frankly, if internal audit's consulted on something, there's nothing that says they can't come back and audit that at some future date. So that's another component too, is help them better understand what you're doing. And if they're a part of that build process, the audit process down the road becomes a lot easier too, because they're just more well-versed in it. They better know the stakeholders, they understand the process, et cetera, et cetera, et cetera. So I think the overarching point here is to say, this all ties back to the way Kevin opened it, to say that there's risk here. How do you engage the risk stakeholders within an organization to better help build out the foundational programs, assessment processes, metrics, monitoring, et cetera, that not only management's going to do, but internal audit, ERM, executive management, and the board, right? Thinking about those things proactively is always going to be much easier than figuring that stuff out reactively or chasing risk that, one, you may not have even known was there before, or two, came up because of the way a program was structured and we didn't anticipate that much volume being there, and now there's a lot of volume, and now what was a small risk is now a very, very large risk and a daunting risk to ultimately get your arms around. So just another quick teaser to it, to the 3 lines of defense model, and saying, pull internal audit in. We're happy to help. We want to help. And we understand that, frankly, there can be extreme value in having that conversation sooner rather than later. So the other component too, right? You typically have internal audit, then you've got, risk and compliance. Sometimes that's one and the same, sometimes different within the organization. But I think what we wanted to hit on here, right, is there's a lot of regulatory and compliance risk that sits within the network management function. I'll let Kevin and Heather hit on a few of the items here, but again, this is that tie back to what we were just saying before, is the compliance function, internal audit function, bring them in early and often to have the conversations to figure out how we can build a robust risk management program to make sure that we stay in the green, so to speak, if I'm thinking about our red, yellow, and green bubbles that we often see in our risk assessment processes. So maybe without further ado, Kevin, Heather, take it away with some of your more granular points here.
Sure. Let me take the top 2 sides. First, no surprises. So No Surprises Act came out several years ago. And the goal of the No Surprises Act is protect patients from surprise billing, protect them in cases where they maybe have to go to an emergency room that's out of network for their, for their health plan, or, where they didn't expect to get a out of network anesthesiologist bill. And so this protects all of us as patients, but it required quite a bit of lifting by health plans, and the providers are feeling some of the responsibility as well. But so No Surprises Act requires identification of claims that arrive. Are these no surprises qualifying? What are the conditions on the claim? Hit the requirements of NSA. And then there's something called a QPA, a qualified payment amount, which took plans, and let me say those are the proxy for the in-network average or the in-network median, which is what the members or the patient's cost share is based on. Sounds like an easy figure. Health plans took sometimes up to 2 years to calculate these QPA amounts to be used in No Surprises. And then we had some, when providers get paid under No Surprises, there is an ability for providers to dispute the payments via the independent dispute resolution process. And that was, so the IDR, as it's called, is being used as much as 20 times more than what CMS had originally expected. So, the calculation of QPAs and identifying and claims that were identified as NSA became a lot more important than CMS had originally envisioned. 20 times the amount are getting flagged in IDR. So what kind of risks do we have here? Certainly there's risks for health plans to their ASO groups who they're representing and who they're calculating QPAs and identifying, protecting their members. There's financial risks in making sure that when we calculate the provider payments, participate in the IDR, that the financial payments are correct, and that affects everyone from a health plan's clients, could be their self-insured groups, to to patients. So there's a lot of financial transaction that complexity gets added in No Surprises. So it's important to make sure that you're processing those claims in those scenarios correctly. And then in transparency and coverage, different story. Nothing in transparency and coverage is used to actually change hands in terms of financial transactions, right? This is about transparency of rates. What are the rates between payers and providers? And a lot of this is there are some compliance risks. There's national regulatory agencies can fine as much as $300 or $300 to $5,000 per day, depending on the size of the hospital. Payers can also have corrective actions. This is a little more vague. $100 per day per offense, which is a little bit vague in terms of whether they mean members or instances of problems. But regardless, there are financial penalties. But there's also groups out there like the patients' rights advocates groups who are publishing, which hospitals and which payers are compliant or not. And so it's best not to be on those lists. Your payer organization doesn't want to be on a list that says the rates that are being published are not correct. So there's concerns there, even if it doesn't lead to, financial transactional impacts. Heather, would you like to talk about interoperability?
Yep. Maybe just to, spend a brief moment talking through some of the interoperability evolution for health plans over the last couple of years. Interoperability and patient access final rule has been live for a couple of years now. This particular ruling required public provider directories for every health plan to publish and keep up to date. Also required standardized data file formats for EOBs, for clinical data sets, and more to be made available for patients to access via third-party applications. So we are sharing a tremendous amount of data to our members now at their request via third-party applications. This rule was really kind of the beginning for health plans of many. Currently, there is an interoperability and prior authorization final rule out. Those requirements start becoming due in 25 and 26, and will have huge emphasis on making prior authorizations more timely available to providers, as well as direct to our members via those third-party applications. And then additional data sharing between health plans. So if a member requests to send data from their prior health plan to their new health plan, there's an obligation to make that data available to the new health plan. And that could be another session in and of itself, but it does introduce a significant amount of data sharing that needs to be accurate, that needs to be tied to the correct people at the correct time. And then there's a number of data sets that have been excluded from these rules as well. So we know there is more coming. Pharmacy is one of those data sets that's been notably of less emphasis on interoperability so far. So as we talk about risk management and navigating regulatory compliance, interoperability definitely deserves its place within this conversation as well. I'll bring us to polling question number 2. Hopefully you guys are all seeing it on your screen. The question is, in your organization, has internal audit or compliance been consulted with or audited your network management program? A, yes, B, no, C, not sure, or D, not applicable. Kevin, I'll send it back to you.
Sure. So let's talk about a couple of areas that deserve some consideration in network management as well. Let's talk network adequacy for a minute, and then a little bit about kind of box 4 provider directories. So provider data is I would say a large struggle for most payers. Accurate, complete provider data, which providers, doctors, facilities, et cetera, that make up their networks, and which ones belong to each network, what specialties can they perform, or what services can they perform, et cetera. A HIMSS study, I was reading an article yesterday that there was a HIMSS survey, which is one of the trade associations of health executives, said that 21% of healthcare executives believe they have poor provider directory data. So a fifth of organizations believe that their provider data is not good, which is interesting because that is the backbone of a health plan, right? Having good provider data. And it's a huge burden on providers as well. If you're a health system, you may participate in 12 or 15 different managed care networks that you have to maintain all of your different provider data within. What are the impacts of this, right? There's patient satisfaction issues. I mean, imagine, you look up in provider data and you think, or in provider directory, and you think, okay, I'm going to go to a dermatologist that I think is a network because here it is, and I get there and services are rendered, and lo and behold, I'm out of network. So you can create some major, some significant member abrasion issues by not having good, up-to-date, provider data. There's also major fines, right? If we're talking, especially if we're talking about managed care organizations that are hosting Medicare Advantage plans, having good provider data is paramount, right? It can mean, poor provider data can exclude you from participation in these government programs. It can also lead to fines. So fines can vary by state for commercial networks, but there's been some headlines lately with some pretty significant 6-digit fines, related to provider data. So just one example here of some important component to make sure that you're paying attention to. And then let's take it one step further. Provider data, and Heather will talk about this a little more, powers so many of the follow-on tools. So for example, in value-based care programs, provider data is paramount to getting provider rosters correct, to attributing members to those providers. So we've got a garbage in, garbage out situation if we don't maintain good fundamental data. I'm picking on provider data here, but there's many other and data entities and groupings of data and systems and processes that if left unaudited or without some controls in place, can create some ripple effects downstream. Maybe we also talk. Actually, Heather, I'm gonna pass it over to you to talk about value-based care.
Sure. So considerations for value-based care program management. First, I'd like to draw your attention to the right-hand side of the slide. Based on the most recent healthcare payment learning and action network survey, which they do every year for health plans, just about 40%, a little bit more, of healthcare payments are now tied to alternative payment models that fall within the category 3B, which is shared savings and shared risk, or population-based payments. So value-based care, to Kevin's point earlier, has been continuing to increase. Further suggesting that story, also in the survey, 72% of health plans said that they do believe alternative payment model activity will continue to increase, with the largest being in that shared savings, shared risk category. So as we think about what are some of the biggest considerations for managing these VBC programs, I think the first and foremost is, are your VBC programs and contracts standardized where possible? So recognizing that different lines of business, different geographies might have very specific requirements, depending on the size of your organization, where you do business, but are there contract terms that can be aligned between contracts and providers that participate in a single program? Or when you have similar VBC programs that leverage attribution methodologies like claims-based attribution, can you align those methodologies as much as possible, share part of the technology, so that you can make it a little bit more efficient? Second consideration would be, are your stakeholders collaborating on VBC programs across your geographies, your lines of business, and your product lines? Specific here, can we combine forces and share build costs for new programs that need to be built or enhanced? is there any opportunity to improve the connectivity between the fee-for-service teams and the VBC teams so that it's a more seamless experience for providers and members? Third consideration would be whether or not the foundational VBC capabilities are in place and connected to other parts of the organization. So a couple considerations within here. The first is longitudinal member tracking. It's so important to value-based care programs where you're able to track an individual or a belly button throughout a performance year, their relationship to a provider or multiple providers, depending on the program, and then also have knowledge and systems and processes of that member far beyond the end of the performance year, so you can do those long-tail VBC financial settlements. Kevin made mention to the provider data a couple of minutes ago, but for VBC programs, the provider hierarchy becomes really important. So which facilities have which providers, which locations are participating in specific VBC programs. So if you're contracting with a large system, they might have a multitude of specialties. And if you have a VBC program that really focuses on primary care, it's not as simple as just saying, use this provider roster for this system. You need to weed out the correct specialties, the correct providers, which line of business they're aligned to, and make sure that you've got the right provider hierarchy there so that it can feed all of the different core VBC capabilities from provider attribution or assignment algorithms all the way through financial settlement calculations, provider analytics, and so forth. Contract setup. Does your systems, does your processes allow for documentation and accurate capture of the different types of contract terms and provisions? If not, how is that known so that you can administer your VBC programs appropriately? There's a lot of examples within these foundational capabilities that need to be kind of considered as part of VBC program management. The fourth consideration we would pose to this audience would be, do operational systems have adequate functionality and controls in place to manage VBC programs? So standard operating procedures, those are really a great opportunity to reduce operational overhead and kind of put those controls in place to make sure that all of the internal teams know exactly what they need to be doing and when, so that you can ultimately get to accurate program administration for your VBC programs. And then traceability that can stand up to an audit. So do the systems that you're using have that traceability between systems and data hops, or are the outputs transparent enough to kind of explain results when questions are asked? Or do you have a little bit of black box happening within there? And then last but certainly not least, are operational strategies aligned to desired VBC outcomes? So do the physician incentives align to the VBC program goals? Is the right information being shared with the right audiences at the right time? For example, provider reporting. Are you able to provide insights to the physicians and their support staff at the point of care when they need it? Or are you tailoring analytics more towards the administration side of the house on the provider partners that you're working with, or a combination? All important considerations when thinking about how to really make sure that these VBC programs run efficiently and accurately. If we can go to the next slide, I'll take you through a scenario of kind of this risk mitigation concept in action. This particular situation was a multi-state health plan that operated more than a handful of VBC programs across all lines of business. They intend to implement additional new VBC programs every year, so adding programs to their kind of program inventory, as well as scaling the contract volume. Because they were growing so quickly, they wanted to stand up an oversight process to help them mitigate risks from growing so fast while enabling continued market innovation. So the wheel that you see on the screen is kind of the 7 core VBC capabilities for operationalizing a VBC program, covering things like population management, so which members are part of which program and which providers, to clinical care management, cost efficiency measurements, and financial settlement. Drilling into the quality outcome measurement capability, just to give an example of what this oversight process was intending to do, is prior to program launch, once kind of the design and the requirements are known and built, there would be a process to kind of focus on specific areas within the quality outcome measurement capability to ask questions like, which quality measures are being used for this program? And are they similar to other quality measures that we use elsewhere? What are some of the key business processes and dependencies for running quality measures as part of the VBC program? How are they being calculated and applied to VBC programs? So for example, breast cancer screening HEDIS measure is a measure that we commonly see in VBC programs driven towards primary care. This particular client was processing breast cancer screening results for all of their members, and then the outputs were being sent downstream to the VBC teams, and then they were responsible for filtering the results to apply for that VBC specific population. So super important that the right person keys were used, super important that the right provider rosters were used, but also we needed to understand what other business rules might have been in there. And then what controls were in place, what documentation existed, and how are stakeholders educated on this part of the world. Through this oversight process, a lot of different materials were being looked at, from standard operating procedures to system solution architecture diagrams and so forth. One of the key findings that came out of this process was for a particular VBC program, for the quality measure results, there was a key business rule that didn't get applied correctly, which ended up understating the rates for each of the quality measures that were used to evaluate that quality performance within the VBC program, which, if not caught, would have resulted in them missing kind of the performance thresholds for their VBC contracts. Fortunately, this oversight process was instituted, so we were able to identify that this rule was missing far prior to calculating the financial settlements for this program, and there was plenty of time to kind of identify this issue and remediate it. And so then the payments for this VBC program were able to be processed and issued to providers accurately without this issue, potentially avoiding provider abrasion as well. So I think I say all of this to really illustrate some of the complexities involved in VBC core capabilities planning, as well as kind of the importance of having that proactive oversight and review process so that you can catch issues and plan for those prior to information being shared externally that may need to be reworked. With that, I think we can go to the next slide, which leads us into our third polling question. So the third polling question that we have today is, are you confident that your organization is taking appropriate steps to manage risk within your network management strategies? First option is yes, we are confident in our approach to risk management. Second option is yes, but we have areas that could be improved. C is no, we do not have a risk management plan in place. D, not sure, would need to learn more. Or E, not applicable. I will give everybody a minute to answer that question. And then we will talk a little bit about some of the common pitfalls. So I think the headline in this slide is really that regardless of whether you're instituting a new high-performing network or a value-based care program build or scale, your strategies need to focus on bringing together systems, data, and operational resources. The first thing we've observed is that investment in new systems or vendor solutions do need to have a strategy in place. They don't automatically equate to minimized risk. When you're investing in a new system, when you're considering a new vendor, make sure that you're planning for transparency. So in the example of vendor solutions, have upfront conversations with the vendor about how are they able to help triage questions that you receive from your stakeholders about how the vended solution works. Will you have the output to enable audit process to come to life and be able to explain the end-to-end? Second kind of thing we've seen is investment focus limited to pockets of network management functions. So we might have, as a health plan, decided to make a large investment in one area, maybe the exchange line of business, but their needs may be very similar to needs in another area of the organization. So is there a possibility to, bring other stakeholders along in the journey through investment to really maximize your ROI? Examples that come to mind here is if you're standing up a VBC program, and that VBC program could be leveraged across lines of business or geographies, really have conversations with those right stakeholders to see if that investment dollar can go further. And that leads us right into our next item, but insufficient stakeholder engagement and planning efforts. So whether it's a lack of internal audit or not having even providers come to the table in a limited capacity to really understand their needs, or operational teams. So you might have an implementation team that is designing a beautiful end-to-end solution for a network management strategy, but once it gets launched, when the operational stakeholders are in there running operational tasks, there's a list of enhancements that may need to be worked in. So having those stakeholders included in planning efforts can really help get a more robust view of, okay, what is core success criteria when implementing a strategy? What are the nice to haves? What are the need to haves? And then last but not least, but a reactive approach to risk mitigation. I think we've all seen headlines over the last couple of years. We all want to avoid being in the headlines, but the more you can be doing as a health plan up front to plan for risks to happen, or plan to avoid risks happening during planning phases, the more proactive you can be at having an approach to avoid kind of that negative press or some of those other factors that come into play with reactive approaches to risk mitigation. Garrett, anything to add on this piece?
Absolutely. Yeah, maybe if you could just take it back one quick slide so that we have it up for everybody. But I think, right, a couple of the things that really came to mind when you were saying those topics, Heather, right? So the leftmost tile, when we talk about vendor solutions, right, we see this all the time. We're going to go and buy it, and it's that vendor's problem, and they're going to, help us fix it and or solve it. Do your due diligence on the front end, right? I think you all have probably been a part of, a vendor selection process or a situation or circumstance that didn't go according to plan. So spend the time up front, look at their SOC reports, better understand their references. How have these tools been customized to fit some of the specific use cases that you all ultimately have? So I can't stress enough to spend enough time in that vendor selection process to make sure that you're identifying the best possible partner. Heather mentioned it, right? That in insufficient stakeholder involvement. Again, right, here's my plea for internal audit and compliance. Bring them along for the ride, right? We're happy to play in those conversations and, right, share methodologies, share some of the tool sets that exist around how do we identify things that may be going off plan as a part of just planning. And then I think the last piece around that reactive risk mitigation, right? Document what those risks are. They're going to change. I think that's the one thing that we can say with certainty is that if the risk started here and we had the mitigation activities to feel good about it, what happens when that program grows or scales, or a new vendor solution comes in, or a new data source comes in, right? So continue to monitor that risk process and make sure that you're still have those controls, processes, people in place to, effectively mitigate that approach to your acceptable level. So I think all of these things have that really key tie back to what, frankly, I think internal audit can bring as a value proposition to, those of you in more operational functions.
So, I mean, a few of these bars are similar themes, but certainly we need a comprehensive strategy for network management. I mean, Heather talked a little about, the issue that she saw one of our clients with quality reporting. I consider how to simplify the reporting and the measurement that you're doing. Are there ways to use, a smaller set of quality measures, or you reuse similar network providers to build a new network? Are there ways to leverage existing financial settlement models? So I guess the point is, can you simplify in terms of comprehensive strategy? Simpler is easier, and usually creates less risk, so long as it still affords the competitive positioning that you're looking for. A robust work plan and then stakeholder engagement. We need to do those hand in hand, right? So we want to make sure that we're building new programs or new capabilities within network, that we're considering all of the different stakeholders, and we're building a robust implementation plan, to take care of it. And then Garrett's plea for make sure you bring internal audit in right away. I was thinking we're about to embark on an addition on my house, and we have to go. We went through a permitting process, and we've got a building inspector that, of course, will come out. Many of you have gone through this, and in some ways it slows the project down. We've got to wait for inspections. The inspector might find something that will cost us some money. But at the end of the day, it's nice to know that the addition that's been built, that the footers are poured correctly, and that the electrical has been wired correctly. And it's also a way to make sure that your vendors and the contractors that you've hired are doing the right thing, that they're building according to the code, that they are all working in concert according to the plan. And it can be another set of eyes to make sure that that your project is running smoothly, and it has the and foundationally is correct. So maybe an analogy there. And so you want to make sure that your compliance strategy is baked in, as you're taking on these programs. Now, what if you already have programs? We've heard folks talk to us about, look, and maybe if we go back to the value-based care poll question for a second, how many value-based care programs? 17%, so a sixth of respondents said 10 plus. 10 plus value-based care programs is a lot. So how do you go about auditing all of those? Where do you start? And Garrett and Heather and I can talk with you about, we in doing audits, in working on building some of these capabilities, we've developed some frameworks for how to break apart the different component pieces. That could be program by program, but it could also be component by component. So there's, in value-based care programs, population identification, financial settlement, quality reporting, integrations with providers. So how do we break those down and build a roadmap for how to make sure that your programs are compliant over time. Or with regulatory programs like NSA, there's 15 different pieces. How do we take those on in their various as they get built? So so in any case, and maybe let's flip to the next slide. Along those lines, I mean, we have, Garrett and Heather and I have gone to market, together, where we'll help our clients with some rapid assessment. So bringing both the practitioner's capabilities as well as the capabilities of internal audit, looking at a problem from both of those lenses. We've built some of these things. Garrett knows how to make sure that that what is happening is not causing undue risk, that is matching with the 3 lines of defense model, et cetera. And so we can take a look at certain areas of the organization or different programs to determine risk levels, to identify some potential mitigation solutions to how to correct those, and then as you go forward in building additional programs, how would you bake in an audit perspective as you go forward. Garrett, more to add here?
I think that's a good wrapper you put on it there, Kevin. Right, it's integrated throughout, right? I think of it as integrated audit. Let audit consult with you and build it as you grow and build your programs. I think that's probably the overarching messaging that we would drive throughout today's conversation. So hopefully that was, a key piece that you took away, but also found, some of the things and the stories that we shared informative. And I know we've got a couple minutes of time left here. So we've got one last polling question that we'll hit, and then we can open it up for some questions. I can go ahead and read it since I got the mic hot. Would you like Baker Tilly to reach out to you to discuss risk management assessments further? A, yes. B, no. C, not sure. D, not applicable. So remember to hit the submit button on your questions. That was our last polling question, and now we've opened it up for questions. So if anybody has questions, as we teased at the very beginning, please put your name in there, because if we don't get a chance to get to your question specifically, or if we don't answer it in full detail, we will absolutely follow up with you and get to the root cause of what your question ultimately was. So maybe take a minute and put any questions that you all may have, and I'll do a quick check here to see if there's anything that has come through.
Maybe a quick recap of some of the polling questions as we go along. Poll 2, has your organization, has internal audit or compliance been consulted when you build network management programs? 38% said yes, 24% said no. Others were not sure or not applicable. That sounds like that's promising, right? That sounds like many of you are engaging with your internal audit organizations. Then poll number 3, are you confident your organization is taking appropriate steps to manage risk within network management? About 1 out of 5, 19% said yes, we're confident. 30% said, yeah, but we've got some areas for improvement. And 5%, only a few responses with, we don't have a risk management, in place. So some of you feeling pretty good. Others know that there's room for improvement.
No questions have come through. So with that, we have the slide up, our contact information. Please, if you have any questions, follow-up materials are going to be posted, just as we said at the beginning of the webinar. But we just want to take a quick moment and say our sincere thanks for attending. We really appreciate it and look forward to future dialogue and conversations. Our contact information, as mentioned, is on the screen, so please reach out if you would like to hear more. And again, thanks so much for participating in today's conversation. We appreciate it, and have a great rest of your afternoon or morning for that matter. Thanks all.
Thanks so much.
Thank you.